Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for a successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you, everyone, for joining us for Conversations in Acute Myeloid Leukemia, really looking at novel therapies targeting the immune system for elderly and unfit patients. During this segment, we'll be discussing the current treatment and management strategies for older patients with newly diagnosed AML. My name is Tapan Kadia. I'm in the Leukemia Department at MD Anderson Cancer Center in Texas. And I'm joined here today by my illustrious colleagues, Dr. Dan Pollyea and Dr. Eunice Wang. Dan and Eunice, great to see you. I think let's start this conversation by talking a little bit about, how we first start evaluating patients who are older and how to determine whether they're frail or whether they're eligible for intensive chemotherapy or low intensity therapy. This is always kind of a topic that people argue about. And how do you do it at your institution? Dan, you want to get started?
Yeah, it's a great question. It's, I think this is a super subjective thing that we would like to make more objective, but it's really, really hard. At our institution, we talk a lot about Ferrara criteria. We talk a lot about, the AML score, the online calculator that you can plug data into to have it spit out, your patient's chance of a treatment-related mortality event with intensive induction chemotherapy. But I think still most of us just use the eyeball test, looking at organ function, performance status, age. I think that's kind of what we're doing and what we, would like to, have a better, more objective way of doing things. I think the big change now is what to do with biological risk factors and how to sort of separate that metric from, some of these more host-dependent issues of, related to frailty and comorbidities. But I think that's kind of an interesting new twist.
Yeah, I agree. Absolutely. I think that it's tough. I think same here. We kind of do that eyeball test. You sort of know when a person is going to be frail for intensive chemotherapy. But sometimes, more recently, we've also been incorporating some of the sort of the genetic risk into whether or not I'm going to give intensive chemotherapy. So it's not just the patient's frailty, but hey, look, you got core binding factor AML versus look, you got a really high risk P53 mutated AML. Eunice, do you take any of those into account, or how do you assess frailty and comorbidities when picking treatment?
Yeah, I think it's a complex dynamic. I think there's certainly subjectivity from the physician's point of view, also individuality from the patient's point of view. I think a lot of nowadays we have a lot more shared decision making. We have factors like economic, logistical, financial even, playing a role, individual goals of care. We have patients that certainly could be candidates for intensive chemotherapy but don't want it. So I think we've moved away from, and I think this is reflected even in the more recent NCCN, we've moved away from using age alone as a criteria and moved more into this holistic where we're not saying you're 60, 65, you're 70, whatever, but we're saying, I think most of us would agree 75 and above for our criteria is unfit. And I think the gray area is that 60 to 75-year-old zone where some people are incredibly fit and robust and vigorous and want everything done. And then there are some really old-looking 60-year-olds which really don't want anything. And again, we have that sort of gestalt, like my nurse practitioners and my providers, this person is not a candidate. And we'll say, but they're 55. And then we go look at them and we go, oh, yeah, no intensive chemo for you. But you bring up a really good point. We're getting to understand some of the therapies for intensive versus less intensive, and we're moving away from sort of the ELN, which is really younger, fitter, intensive therapy, to newer prognostication systems for not only who is fit, but who is fit biologically. If you have per the ELN, something, a type of cancer that is not going to respond to intensive chemotherapy, you might be fit, but we're not going to give you intensive chemo because your disease does not fit the category that it's going to respond. So I think it's a changing world out there, and I think this fitness is going to be something that we're going to continue to debate as potentially our standard of care is changing, and even as we speak.
Yeah, I think you really crystallized the point. I think there's an evolution in how we're assessing fitness and whether it's just biologically fit for the patient, but also biologically fit in terms of the disease. One last question on this topic for both of you. You guys can speak up, whoever, but a lot of times we talk about fitness of intensive induction chemotherapy or whatever we were giving them for remission induction. And then do you necessarily use that same judgment for when you're considering these folks for transplant? Like, for example, I may have a patient where I may say, look, I think I can get you into remission with lower intensity therapy, but you're still someone I think should go for allogeneic stem cell transplant, which many think of as a very sort of intensive approach. Do you ever have that paradox in your practice?
So just to speak, and I know Dan probably has a lot to say about this as well, but I tend not to make that 100% judgment about transplant, no transplant at the time of their presentation of disease. I've seen a lot of patients look really unfit and not look great, but that may be because they've been suffering from severe anemia for weeks and they have some comorbidities. And once I treat them with a couple cycles of venetoclax-based therapy, they perk up. The availability of haploidentical and post-transplant Psi and some of those other modalities has allowed us to have a broader range of donors and to perform transplants in people that we wouldn't have a few years ago. So I sometimes reserve transplant eligibility until after they get a couple rounds of therapy, and then I reassess their quote-unquote eligibility for that. Dan, what are your thoughts on that?
Yeah, can't agree more with you with what you said. I'll just add one thing that, beyond the sort of ability of a patient to become more fit for a transplant with effective treatment of their disease, I also think that for many patients, a non-myeloablative or reduced intensity conditioning transplant is not more toxic than standard, intensive induction chemotherapy. And I know sometimes that's hard for people to wrap their heads around because a transplant is such a big undertaking, but I definitely agree that there are patients who are just fine candidates for a non-myeloablative transplant that would do really, really poorly with intensive induction. So decoupling those things is important, I think.
Yeah, I think that's the point. That's excellent. Great. Okay, guys. So we have a lot of new therapies now in AML, which we did not have several years ago. So let's get into some of these. I want to hear about, sort of the revolution in AML with the incorporation of venetoclax in some of these therapies. And we'll talk about FLT3 inhibitors, Glastigib. I think really important therapies, finally showing some survival benefit. Dan, you want to just maybe talk us through quickly the low-dose Ara-C and HMA and venetoclax and what that's meant for patients and how you use it?
Yeah, I think as you well know, sort of straddling in our careers, the sort of before and after of effective lower intensity therapies such as these. I mean, it's a whole new world of options for patients who really had nothing effective or to be enthusiastic about, if they were older or unfit for intensive induction, to now having real options. So, venetoclax-based therapies with either low-dose cytarabine or an HMA or Glastigib with low-dose cytarabine for these unfit patient populations, having these options of therapies that are better than a previous historical alternative is game-changing. And so, still a lot more to do. We have a lot more way, to go to see this through and to keep moving the needle. But I think these represent really impressive, first steps toward a much better treatment outlook for these patients.
Absolutely, couldn't put it better. Eunice, you've done a lot of work in the development of FLT3 inhibitors, particularly for older patients in the front line. How do we use FLT3 inhibitors? HMAs, HMA-VEN? What is the approach that's best for these folks?
Well, I think technically, with the results of the GILT-AZA versus AZA trial, there was no improved survival with the combination upfront GILT approach with AZA as opposed to AZA alone. Interestingly enough, though, in that trial, patients who were in that truncated arm that just got GILT alone had about a 20% overall response rate. So I do think targeted therapies belong in the upfront setting. The perfect example of that is the use of the ivosidenib monotherapy has same efficacy in the upfront setting as it has in relapsed refractory. And I suspect that targeted therapies are going to be part of our regimen. I think the beauty of using some targeted therapies for these patients is that they're much less toxic. I think whether you give anything with venetoclax, there tends to be an associated myelosuppression, which can be poorly tolerated in some of these older, unfit individuals, particularly patients that may have baseline severe cytopenias to begin with, and then you're sort of layering on the venetoclax. So I think FLT3 inhibitors right now are not indicated in the frontline setting, although we have upfront trials looking at triplet gilt ven aza, which may prove to be instrumental. But those regimens are going to use a very truncated ven dosing if we're going to move that forward. We do know that some people are using because we know that FLT3 is a mechanism of resistance, that the FLT3 mutant clones get selected out with ven HMA therapy. I've seen patients get ven-aza up front, and when their disease comes back, and maybe doing sequential FLT3 inhibitor therapy after ven-aza if you get emergence of a FLT3 mutation. In general, though, I think using some of these targeted approaches in elderly patients really opens the door. These are patients that even a few years ago we would say you should go to hospice, and then we were treating them with aza alone, and then even with ven-aza, and like, well, maybe they're not good with ven-aza. That's still too toxic for them. So I think some targeted single agent therapy or LDAC-based approaches are allowing another subset of even more frail people to get therapy.
No, great points. I think that you're right. As we combine these new agents in the front line or even the relapse setting, we really have to be cognizant of the safety and really study these in clinical trials before we sort of democratize these to everyone. So I think that's what these studies are for. Dan, Eunice brought up ivosidenib in the front line as a single agent. Wow, just a single agent therapy for old, frail patients. And enicidimab also, both of those, as you know, approved for frail older patients who are ineligible for other therapy and actually seeing nice responses. Agile showing a nice sort of survival benefit. Can you take us through sort of frontline IDH mutant patient treatment who are older and unfit?
Sure. Yeah. I mean, I think there's randomized high quality data for the use of ivosidenib and azacitidine in this unfit IDH1 positive newly diagnosed population, and I think we're all really impressed by the results from that study. And I think it's a very viable option, for use in that population. Of course, the enicidimab plus azacitidine data are not the same there. One could argue that the reasons why that may be, but that's not an approved therapeutic path. And I think while ivosidenib does have single agent approval in the upfront unfit setting, I think, I really do try to use it with azacitidine if at all possible, just because of that really high level data. Now, there are, of course, some patients that are probably just too frail for that combination. And in those situations, the single agent IDH1 inhibitor is available. But I really do try hard to get patients who might be eligible for this treatment to treat them with both ivosidenib and azacitidine.
Yeah, great point. So we do some similar things. We also consider triplets in some cases on clinical trials. And finally, we forget, galactakib, the hedgehog inhibitor, it's one of the few drugs that we have demonstrated a survival benefit. So low-dose Ara-C plus galactakib, response rate around 30%, 25-30%, compared to low-dose Ara-C alone, had a survival benefit, 8.8 months versus 4.5 months or 4.9 months. So really, effective. We forget about this, and we use it occasionally in our patients. I wanted to get your feel on galactakib. Do you think there's further development beyond just low-dose Ara-C? How can we further implement this or incorporate this?
So, I think that one of the benefits of the galactakib LDAC that I've used in my patient population, again, is for treatment of that extremely frail individual. The downside right now of the HMA therapy, whether you use azacitidine or decitabine, is the need to come in daily for IV or sub-Q injections. We don't have an oral HMA approved in the frontline setting for these elderly individuals. LDAC can be, at least in our center, administered at home. So that's something that patients can do, and just like an insulin shot. So the combination of a pill with an injectable low-dose cytarabine, I think, has been an approach that has certainly been effective for some of my older patients. LDAC is also safe in patients with kidney dysfunction. It's very well tolerated, and it's something that really minimizes their trips back and forth to the center, which for some of these elderly, frail individuals can really be challenging, getting in and out of a car, a walker, wheelchair, that type of thing. So I think having that option to just have them come in for occasional count checks and do all of that 10 days and pill form is something that really could be something that we're going to see more of moving into the future.
Yeah, fantastic points, Eunice. Thanks. And as we close out and as we go to further sections, I think one of the important things is that we think about in older patients, particularly those who aren't eligible for transplant, are maintenance therapies. Oral AZA is approved, of course, among those who had intensive chemotherapy, but other maintenance strategies may be available, investigational, immune therapies, etc. Are you folks using maintenance therapies in your older upfront patients?
Dan, is that something you're using? Just oral ven or anything like that?
Yeah, the maintenance is sort of baked in when you do a venetoclax or a glastigate-based therapy or ivosidenib for that matter. I mean, in that we don't really stop it, but in the spirit of sort of oral azacitidine, which is of course approved for maintenance after intensive induction, or like a FLT3 inhibitor, which may have a role in the post-transplant setting. I personally am not doing that intentionally in older, frail populations, but I am continuing the therapy that we started with, with dose reductions, et cetera, to make it more manageable until relapse or intolerance.
Yeah, indeed. The sort of the built-in maintenance that's present in all these therapies. Guys, I really want to thank you. I think we had a great discussion. Thank you for joining us on this segment on the current treatments and management strategies in AML. Be sure to click on the landing page for this activity and claim your CME credit, access supplemental slides, as well as other topic segments. Great to see you all. Thanks.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.